Hello everyone, I am Dr. Saida Khadija Fatima and I'll be talking about osteomyelitis in bones and joints pathology. Osteomyelitis is an inflammation of bone and marrow. It is always secondary to a systemic infection going on in the body and always manifest as a primary focus somewhere in the long bones of the adults or children or even infants. All types of organisms can cause osteomyelitis like viruses, parasites, fungi and bacteria. The most common bacteria is Staphylococcus aureus, E. coli, Neisseria gonorrhea, Haemophilus influenza and Salmonella. Mycobacteria causes typical Mycobacterium osteomyelitis affecting mostly the spine. So the bacteria like Staphylococcus, E. coli, Neisseria all cause pyogenic osteomyelitis. 80 to 90% of the pyogenic osteomyelitis is because of Staphylococcus aureus. Now there are three routes of spread of infection. Either it is hematogenous spread or it is extension from a neighboring site, that is contiguous site, and the third is direct implantation. Direct implantation can be because of any penetrating injuries or wounds or any pathological fractures, or it might be implanted as a bacterial focus during surgery. Any surgery related to vascular or bone pathology. Now the hematogenous spread, it usually affects the metaphysis of long bones. And the initiating bacteremia is when the bacteria is present in the vascular supply. So initiating bacteremia may stem from either any mucosal injury happening in the skin, or it may be because of any hard vigorous chewing of hard food and the primary focus might lodge into the jaw, the alveolar sulcus, causing jaw osteomyelitis, which is also called as sclerosing osteomyelitis of Gary, and either it can be due to minor infections of the skin. It is more common in boys or the male sex, and if it affects the boys or adolescents, it is 5 to 15 years old people which are majorly affected, and elderly people mainly because of the pathological fracture happening on and off due to osteoporosis. Old age people are also more prone for developing pyogenic osteomyelitis. In drug addicts also, the focus of IV cannula might be a mode of transmission of bacterial infection. Now coming to the pathogenesis of osteomyelitis. So how does the organism enter and what exactly does it do to cause the necrosis of bone? As I said, pyogenic osteomyelitis is mostly because of Staphylococcus aureus, 80 to 90% of the cases. And here what exactly Staphylococcus aureus will do is, there are certain cell wall proteins which are present in these organisms which will bind to the bone matrix components such as collagen, and that will help this bacteria to adhere to the bone. And then there are certain bacteria like E. coli, Pseudomonas and Klebsiella which will be entering through the genitourinary tract infections and also through the venous channels in the intravenous drug abusers. Mixed type of bacterial infection can occur whenever there is any implantation through surgery or in any pathological fractures. If it is a neonate, then Haemophilus influenza and group B streptococci are mainly frequent pathogens. And if it is an individual who is predisposed to sickle cell anemia, then Salmonella is the most frequent infection. So depending upon the location and the vascular supply, this stages or the route of spread will differ. So if it is a neonate, then mostly the metaphyseal vessels will be involved. As there is the growth plate will not be formed in neonate and up to puberty, this will result in traveling of the infection from the metaphyseal vessels to the epiphysis, involving the entire joint. So what happens here is whenever there is entry of the organism into the bone, mainly in the metaphyseal region, then that will spread into the medullary cavity. If there is a spread into the medullary cavity, then marrow spaces are involved. Also, because the metaphyseal vessels are involved, there will be thrombosis of the vessels because of lack of blood supply to the bone. So what happens here is there will be ischemia or lack of blood supply because of raising of the periosteum due to pus accumulation, and that all this will lead to necrosis of bone. So that necrotic bone is called as sequestrum. Suppurative inflammation extends through the cortical bone to involve the periosteum. So whatever we see in a sequestrum is nothing but a necrotic bone surrounded by suppurative inflammation, and if that goes on to accumulate, that will raise the periosteum, which is the outer lining of the bone. So here you are seeing the joint cavity, which is mostly the metaphysis and epiphyseal region, and the articular cartilage is surrounded by pus. So that will eventually raise the periosteum and lead to again stripping of the vessels away from the bone, leading to more necrosis of the bone. So eventually what you get is a primary focus of osteolytic pus-filled bony lesion. So this is how a microscopic picture of a sequestrum will look like. This basophilic ragged edge of the bone represents the sequestrum or the necrotic bone. This will be surrounded by acute and chronic inflammatory cells. So we can see a giant cell also here, along with proliferating vessels seen in red color, and here again a giant cell. So this entire thing should be seen as a microscopic picture of acute osteomyelitis. So changes associated depends upon the stage. So there are 3 stages. You can classify the osteomyelitis into 3 stages. So acute, subacute and chronic. Acute phase, what happens is neutrophilic inflammation can be seen, and you can see necrosis of bone cell as I've shown you earlier. So that will happen in the first 2 days. Then as the bacteria and inflammation spreads into the medullary cavity and the marrow spaces, it will travel through the Havrasian canals to reach the periosteum. So this raises the periosteum, causing subperiosteal abscess. So subperiosteal abscess can dissect along the bone, lifting the periosteum, which further impairs the blood supply. So what happens here? Lifting of the periosteum causes stripping of the blood supply from the affected region, leading to dead bone, that is called as sequestrum. Dead bone is known as sequestrum. So what happens next is there will be rupture of the periosteum, leading to soft tissue abscess. So periosteum will break down. Now the pus tries to accumulate and try to reach the surface of the skin. So that causes formation of a draining sinus, that is called as cloaca. Then comes the reactive bone formation around the dead bone. So that's called as involucrum. Brody's abscess is nothing but a small intraosseous abscess that is inside the bone, which is formed because of involvement of the cortex. That will be again surrounded by a reactive bone. So what you are seeing here is a sequestrum inside a osteolytic focus surrounded by a reactive bone. This is again a ragged end necrotic dark basophilic dead necrotic bone surrounded by inflammatory cells, which is seen in the marrow cavity mostly. Again, a radiological picture of osteolytic lesion. Again, this is an image showing the sequestrum, which is a lytic lesion surrounded by reactive bone formation, which is again isodense, and then there will be a draining sinus connecting to the skin or the soft tissues, that's called as cloaca. In 5 to 25% of the cases, acute osteomyelitis fails to resolve, and that might enter into chronic osteomyelitis stage. Chronic infections, usually because of delay in diagnosis or extensive bone necrosis, are diagnosed later, and inadequate antibiotic therapy, improper therapy, or surgical debridement, which can be improper in acute osteomyelitis, or either in immunocompromised or immunosuppressed patients with weakened host defenses, an acute osteomyelitis can convert into chronic osteomyelitis. There might be acute flare-ups in the course of acute chronic infections as well, and it can occur spontaneously or may occur after years of dormancy. The only difference between acute osteomyelitis and chronic osteomyelitis is the inflammatory component. Vertebral osteomyelitis, if the focus is in the vertebrae and if it affects the disc as well as intervertebral, that is intervertebral discs and plates and the bodies, then it's called as vertebral osteomyelitis. It spreads through the disc to adjacent vertebrae as well. Mostly it is caused by Staphylococcus aureus, E. coli, Salmonella, Brucella. This occurs by hematogenous spread mostly, and the risk factors are IV drug abusers, urinary tract infection, and urological procedures. So all which is nearer to the trunk of the vertebrae. Now infection spreads into the vertebrae. So here you are seeing the body of the vertebrae being affected, and the infection might drain into the intervertebral disc and might destroy the intervertebral disc as well. Outcomes of vertebral osteomyelitis is the vertebral collapse can occur with paravertebral abscess. There might be spinal epidural abscess as well with cord compression, and there might be compression fracture of the vertebrae. As I said, besides the pyogenic bacteria, mycobacteria cause a different group of osteomyelitis, which is mycobacterial osteomyelitis or tuberculous osteomyelitis. This is always secondary to primary elsewhere. Either it might be due to direct extension, example from a primary focus into a rib, or from tracheobronchial nodes into the adjacent vertebrae, or it can spread via circulation also. The bone infection might persist for years, and the patient typically might have localized pain, low-grade fevers, chills, and weight loss. Common sites are the spine and metaphysis of long bones, especially the greater trochanter of the femur. If it affects the spine, it is called as Pott's disease. Spine is involved in 40% of cases of mycobacterial osteomyelitis. And here what happens is similar to the vertebral osteomyelitis, the infection breaks through the intervertebral disc to affect multiple vertebrae and extends into the soft tissue. So this will lead to permanent compression fractures and produce scoliosis or kyphosis and neurological deficit as well. So this is a compression fracture in pod spine leading to compression of the spinal cord, as eventually leading to neurological deficit. And microscopically you can see typically here in this picture you see necrotic bony fragments, the giant cells and granulomas with epithelioid cells. Particularly in this picture you cannot see caseous necrosis, but like the mycobacterial picture elsewhere, you see caseous necrosis, granulomas and necrotic bony fragments in a case of tubercular osteomyelitis. Now coming to the complications of osteomyelitis, it can be either septicemia or acute bacterial arthritis. It can be pathological fracture, squamous cell carcinoma, secondary amyloidosis, chronic osteomyelitis, endocarditis, sepsis as well. Sarcoma can also occur in the adjacent soft tissue of the infected bone. Here I am showing a short pathogenesis or short depiction of how exactly the stages of osteomyelitis occur and the different stages of cloaca formation, sequestrum, involucrum formation, the causes, etc. So please follow. This is how the bacteria attaches to the collagen of the bone, and leukocytes, that is neutrophils, are attracted to the site. So the blood flow is stopped because of metaphyseal vessel thrombosis, leading to a focus of necrotic bone which is called as sequestrum. Sequestrum loses contact with the normal blood supply in the Havrasian canal. Avascular nature of sequestrum is very resistant to antibiotics. So this necrotic area is surrounded by reactive bone. Thus, if it drains into the adjacent soft tissue and skin surface, it is called as cloaca. So this completes our osteomyelitis topic. I hope you understood the topic, and if you have any doubt, please mention in the comments.